Hello everyone, happy afternoon, a very good afternoon. Am I audible and visible? I think there's a lot of issue with the audio video, is it? Just give me a minute, I'll be back. Yes, am I audible and visible now, everyone? Okay, that's great. So, happy afternoon, everyone. A very good afternoon. I hope and I believe all of you are doing well. So, today we are going to discuss a very, very important topic that is bone tumors made easy. So, we'll try to look at the important points for bone tumors. So, basically, this is a session which is in the series of the short topics like the must know topics, and also the fast series, that is the first aid simplified teaching. So we are trying to integrate the topics from the USMLE First Aid as well, and we have added some extra points. We'll be adding some extra points and some extra images to it. Okay, so I have shared the PDF on the Telegram group already. I hope all of you have got it. And yes, let's start with it. Why are we doing bone tumors today? Basically, because the timetable that we are following on the Telegram group, in my previous YouTube video also I shared the same. So today, in our today's target, we have bone tumors, arthritis, and we'll be completing orthopedics, right? So that's why I thought of simplifying this topic for each one of you, right? So let's start with it. The first thing in the bone tumors is knowing the location in the bone where which tumor occurs at which location, because Arti is saying I'm not audible, visible. If anybody, like, can you just confirm if I'm audible and visible, everyone here? Okay, right. So we are going to learn about the location of the bone tumors first, that which tumor occurs in the epiphysis, which occurs in the diaphysis, and then we will go on to the individual bone tumors, right? So starting with the first one, very very important, what bone tumors occurs in the epiphysis. Remember that giant cell tumor, so you can see this giant cell tumor occurring in the epiphysis of the bone. So the first trick that you should know is remember ECG. What is ECG? ECG basically is the tumor occurring in the epiphysis are chondroblastoma and giant cell tumor. Yes, Medico, definitely this is for FMG students also. This is for everyone. Okay, so the tumor occurring in the epiphysis is chondroblastoma and giant cell tumor. We will come to that. How do we differentiate the two? So first point to be remembered is ECG, that is epiphysis is chondroblastoma, not chondrosarcoma, and giant cell tumor. What tumor occurs in the diaphysis? Most important that we need to know in the diaphysis. Remember, we have Aimingsarcoma, osteoid osteoma. These are in the diaphysis. Very very important, right? If not anything else, at least remember Aimings and osteoid osteoma are in the diaphysis. Now, what is the typical point about osteoid osteoma that you should be knowing here? So you can see that osteoid osteoma, this tumor is based on the cortex of the bone, right? This is a cortical tumor. Within the cortex is what we have, and we have the nidus within in osteoid osteoma. So remember that osteoid osteoma, which is the bone tumor, which is based on the cortex of the bone, which is within the cortex of the bone, that is osteoid osteoma. And therefore, what is the investigation of choice for osteoid osteoma? Because the tumor is within the cortex. So remember, for bone cortex, C for C, it is CT scan, which is the investigation of choice. While for other bone tumors, it is MRI to look for the extent of the bone tumors, the extra osseous extent of the bone tumors, or even to look for the skip metastasis, Basically, we do MRI. Okay, we do MRI. The first investigation for bone tumors is X-ray. The first investigation for any bone tumor is X-ray. Right? If it is osteoidostoma, then we go for CT. If not, then we go for MRI. Okay. So, Aimingsarcoma and osteoid osteoma basically is in the diaphysis. Look at the location of the osteosarcoma. Osteosarcoma is in the metaphysis and it has a dense bone, right? The osteoid matrix is what it has. The recent AIIMS exam question and FMGE exam question as well. What is this bone tumor which occurs as an outgrowth from the bone? Basically continuous with the bone and outgrowing from the bone. So remember, outgrowing is exostosis. Exo matlab going out, ostosis. So osteochondroma is also called as exostosis, right? So remember, this is exostosis. So this is the overview of the tumors that you should know. So epiphysis is chondroblastoma GCT, osteosarcoma is metaphysis. Then you have diaphysis is Ewing's and osteoid osteoma. Osteoid osteoma is in the cortex, so we do CT for that. And the outgrowth is the osteochondroma. Now coming to, and you can see one more thing here, this is fibrous dysplasia that you can see here. Fibrous dysplasia has been asked in the recent NEET PG and also in the AIIMS exam. One thing that I want you to remember for fibrous dysplasia, remember FI, like it's femur dysplastic. So remember the dysplastic, the deformity of the femur that we see here is the Shepherd crook deformity of the femur is what we see. Plus we have association with McCune-Albright syndrome where we have precocious puberty and polyostotic fibrous dysplasia with caphiolis spots is what we have in fibrous dysplasia. Okay, that is fibrous dysplasia. Okay, now going on to this table from first aid, I've added some extra images here along with the tumors so that it gives you a better memory. Now, if I ask you what is the most common bone tumor? The most common bone tumor is bone metastasis, right? But here in this session, we are going to talk about the primary bone tumors, okay? So, look at the first one, the benign tumors. We are talking about osteochondroma, osteoma, osteoid osteoma, and osteoblastoma. We saw about osteochondroma that it is exostosis, that means an outgrowth from the bone, continuous with the bone. So, osteochondroma is also called as exostosis. Okay, it is also called as exostosis. As the term says chondro, what is the chondro part in osteochondroma? Remember, it is a tumor which has cartilage cap which is present. So you have an outgrowth like this and above that tumor basically you have this cartilage cap which is present. Okay, the cartilage cap is present here. This is the most common benign bone tumor and common in young age, less than 25 years. It occurs in the metaphysis of the long bones. So remember that basically this is continuous with the marrow space. It is an outgrowth from the bone and it is covered by cartilaginous cap. So if you look at it, the clinical size will be less or more than the X-ray size. What do you think? The clinical size of this tumor will be less or more than the X-ray size. So clinically, when you feel the tumor, it is larger as compared to what you see on X-ray because on X-ray we cannot see the cartilage, right? So what part we will see on the X-ray is only this part, right? This part is what we will see. We will not see the cartilage. So remember that this is a bone tumor where the clinical size is more than the X-ray size since the cartilage is not seen on X-ray. Okay, since the cartilage is not seen on X-ray. That is why. Okay, so if you want to have a look at the cartilage, then what investigation should we do? We should do MRI. And what is the role of MRI? To look at the cartilage cap. So remember the increased thickness of the cartilage cap, increased thickness more than 2 centimeters is suggestive of malignant change. Okay, that is suggestive of malignant change. So if there's a question that to look for malignant change in osteochondroma, what investigation should we do? It is MRI. So remember, it can rarely transform to chondrosarcoma, right? It can turn malignant. In that case, the patient will have increased pain, increased size, and on MRI, you would see the increased cartilage cap thickness. Again, a recent NICT exam question. Right, this was asked in the recent NICT exam, so this is very, very important. Now, going to the next one, osteoma. So, if I ask you osteoma, where did you read about osteoma? In surgery, in medicine, in pathology, related to the colonic polyps. So, we read about osteoma related to the Gardner's syndrome. That is one of your FAP वाले में जो आता है, familial adenomatous polyposis associated syndromes. So, Gardner, remember the trick for Gardner is, imagine a gardener going to the garden getting a thorn prick. So the skin tumor, the soft tissue tumors, the bone tumors is what we get. So epidermoid cyst, then you have the desmoid tumor, then you have osteomas. All of these are seen in Gardner syndrome. And look at this image here which I've added. So this is common with the facial bones, right? So all this which you see here, these are the osteomas that you are seeing here. Okay, all these are the osteomas. So this is common in the facial bones, the surface of the facial bones associated with Gardner syndrome. Next one, osteoid osteoma. So remember osteoid osteoma, that is O and O. So in osteoid osteoma, the trick to remember is the O, remember the first O represents the primary bone tumor and the second O represents the nidus within the tumor. Okay, so that is the osteoid osteoma. And oh ma, that means oh ma, the patient is crying with pain, right? Especially at night. So that is a very, very important clue for osteoid osteoma. It is night pain. Okay, oh ma at night, that means there's night pain. There is nidus, N-I-N-I in osteoid osteoma, O-O. So we already said that it's a cortical based tumor. So you can see that this is the cortical thickening, and within that, so look at this cortex and look at the nidus, the radiolucent nidus within the tumor, right? So this is osteoid osteoma. Now why is the pain more at night? Because this nidus secretes prostaglandins and the prostaglandins are secreted maximum at night. And that is why the pain is maximum at night. And therefore, what relieves the pains? Because the pain is because of prostaglandins. So you block the prostaglandins by giving NSAIDs, and that is why the pain is relieved by NSAIDs. This is the classical history that you would get with osteoid osteoma. Again, the age group is less and it is more common in males. Remember, this is the cortical based tumor and it presents as a pain which is worse at night, relieved by NSAIDs. The difference between osteoid osteoma and osteoblastoma is osteoid osteoma is less than 2 centimeters. Osteoblastoma is more than 2 centimeters. Okay, that is one difference there. And in the center, you have the radiolucent nidus, right? Now, what is osteoblastoma? Osteoblastoma is similar to osteoid osteoma, but the common bone that is affected here is vertebra. So, like you see here, this is a CT, this is the vertebra. Okay, there is vertebral involvement that you see here. So, when you have tumor involving the vertebra, the posterior elements of the vertebra, first think of osteoblastoma, and it is larger in size. It is similar to osteoid osteoma, but it is more than 2 centimeters, and the pain is unresponsive to NSAIDs here. Okay, so the pain will not be responsive. So that is osteoblastoma. And very, very important, what treatment do we use for osteoid osteoma? What is the treatment for osteoid osteoma? This has been asked in a recent exam. Remember, it is radiofrequency ablation. So very important, radiofrequency ablation is used as a treatment for which bone tumor? It is osteoid osteoma. Why? Because we have a small nidus in osteoid osteoma that we need to ablate, that is responsible for causing the pain, the nidus. We can put the electrode and we can ablate the nidus. So remember that RFA is the treatment for osteoid osteoma. Okay, so RFA is the treatment for osteoid osteoma. Next one, coming to chondroma, or basically this is N-chondroma. Okay, chondroma or N-chondroma. So remember that N-chondroma, E is the fifth alphabet N-chondroma, and remember the 5 fingers. So this is a tumor which will be commonly given as, the major clue here will be This is in the small bones of the hands and feet. So which is the tumor in the small bones of hands and feet is Chondroma. So like you see here, there are multiple lytic lesions which can have the internal calcification also, that is Chondromas. And what are the syndromes associated with Chondromas? Multiple Chondromas. The syndromes are Olliers and Maffucci's. Okay, it is Olliers and Maffucci's. So what is Olliers? Remember, all ears is like all ears, all E. That means it is all Chondromas that are present. Maffucci's, M for M, is a mix. Along with Chondromas, what do we have? Remember, Maffucci's MA is MA. We have hemangiomas along with Chondromas. Okay, we have hemangiomas along with Chondromas and Maffucci's. So, all ears is all E, that is all Chondromas. Maffucci's is Chondromas plus hemangiomas. Okay. So this is a benign tumor of the cartilage, that is Chondroma. Yes, absolutely right, Chandni. The hemangiomas, how will you identify on X-ray is, you will see the soft tissue calcification that basically represents the phleboliths. Okay, phleboliths will be seen. Liths matlab stones like calcification will be seen in the soft tissue. That is how you'll identify hemangiomas. Going to the next one, and the 5-star, like the most important and the most favorite for the examiners, that is giant cell tumor. Okay, giant cell tumor. So some important points for giant cell tumor. Remember, giant cell tumor occurs in a giant. That means in an adult patient, like around 30 years, 40 years, not in a child. And giant involves the joint surface. This is the bone tumor which goes till the articular surface. That means it involves the epiphysis and it grows to the articular surface. And look at the appearance of this tumor that you are having here. This is an expansile lesion, eccentric expansile epiphysis. These are the 3 E's for giant cell tumors. That means it is an eccentric tumor, it is expansile tumor, and it involves the epiphysis. Okay, those are the 3 E's for giant cell tumor. Right. And the appearance that you have there is the soap bubble appearance. That is the multiple trabeculated appearance is what we have. So this is the soap bubble appearance that we are seeing here, which is also seen in which other tumor? Which is also seen in aneurysmal bone cyst. Okay, it is also seen in aneurysmal bone cyst. So how do we differentiate the two? This is ABC is opposite of GCT. GCT, giant is in a giant. This is younger age group, that is before the fusion, immature skeleton. GCT is in epiphysis. This one is in metaphysis. So that is how we differentiate ABC from a giant cell tumor. Okay. Now, and tell me, what is the treatment for giant cell tumor? The treatment for giant cell tumor is extended curettage with bone grafting. Remember, this has been asked in the exam many times previously. The treatment for GCT is extended curettage along with grafting, right? No chemotherapy, no radiotherapy there. And we have already seen that this is in the epiphysis of the long bones, common around the knee region. This is a benign tumor but locally aggressive, right? It is benign but locally aggressive. Which are the neoplastic cells in the giant cell tumor? It is not the giant cells, but it is the mononuclear cells. Okay, the mononuclear cells are the neoplastic cells, not the giant cells. So you can get an histopath image also here, where you will have the giant cells, osteoclast like giant cells which are present. So remember that giant cell tumor is also called as osteoclastoma. Okay, there is osteoclast like giant cells present. It is also called as osteoclastoma. Okay. So the neoplastic mononuclear cells, basically they express the rank ligand, the rank L, and the osteoclast like giant cells, they are the reactive cells. Okay, they are the reactive cells. That is why this is also called as osteoclastoma, but remember that osteoclasts are not the malignant cells. Okay. And what do you get on X-ray? We get the soap bubble appearance on X-ray. Okay, we get the soap bubble appearance on X-ray, right? Going on to the next one, so that was about the benign tumors. Now coming to the malignant tumors, that is osteosarcoma, chondrosarcoma, and Aimingsarcoma. All the sarcomas there. Now, osteosarcoma, as the term says, this is osteo. That means bone-like matrix is what you will see. Osteoid matrix. This is osteogenic. That means bone forming. So the matrix that you see with osteosarcoma, it is very dense, bone-like. And look at the periosteal reaction. Okay, look at the periosteal reaction. This is called as sunburst pattern. Okay, so what do you have here? Sunburst pattern is what we have here. Okay, sunburst pattern is what we have here. Now, what is the age group that generally you have osteosarcoma? This is boys, like an adolescent boy, around 16 years, 18 years, less than 20 years is what we have. But can it occur in adults, elderly people also? Yes. So it's basically biphasic. And in the elderly, it is secondary. The primary tumor is adolescent. Secondary when it occurs. When does the secondary occur? Paget's disease. Very, very important. In Paget's disease, what bone tumor can occur? Osteosarcoma. Secondary to radiation, and another important question, familial retinoblastoma. What bone tumor do you have? It is again osteosarcoma. Okay, again it is osteosarcoma. So remember, yes, it's bimodal. It's in the adolescent also and elderly also. Adolescent primary, elderly secondary. Okay. Which part of the bone does it affect? It is the metaphysis. Again, around the knee region. This is very common. So you have the osteoid producing cells here, like the malignant osteoblast here. And what do you have? Codman's triangle. What does a Codman's triangle represent? This is an aggressive lesion. Remember, this is not specific for osteosarcoma. Aimingsarcoma, osteomyelitis, aggressive bone lesions, generally they can give Codman's triangle appearance, or it can give the sunburst pattern. So remember, S for S, osteosarcoma, S for S gives the sunburst pattern. Okay, and this is aggressive tumor, and it is usually responsive to treatment. Remember, surgery or chemotherapy, not radiotherapy, because this is highly radio-resistant tumor. Okay, this is not radio-sensitive. This is highly radio-resistant tumor. Okay, clear with everyone? So that is osteosarcoma. Going on to the next one now, chondrosarcoma. That means this is a cartilaginous malignant tumor. Wherever you have chondro, the type of calcification that you can have here popcorn calcification, right? It is also called as rings and arcs pattern of calcification or stippled calcification that is seen with cartilaginous tumor. Chondrosarcoma means that it is a malignant tumor. That means it can grow beyond the bone, right? Common in the pelvis, the flat bones of the pelvis like you see here, but you can also see that it is growing beyond the bone. This is the bone limit. This is growing beyond the bone, and look at the pattern of calcification here. The ring pattern of calcification, the popcorn pattern of calcification is what we have here. Okay, so this is chondrosarcoma. And remember, chondrosarcoma, the malignant tumor, this occurs in the elderly, okay, more than 50 years. So common in the pelvis, okay, this is common in the pelvis. This is what you should remember. And very, very important, because this is malignant, it can breach the cortex. Cortical breach is a feature of malignant tumor. Another important finding here is end osteal erosion, right? The erosion of the bone from inside. So remember, it can cause end osteal erosion, cortex breach, and this is common in the elderly. While chondroblastoma is a young age group. Okay, this is immature skeleton. So do not confuse chondrosarcoma with chondroblastoma. Chondroblastoma, blastoma generally is a tumor in the pediatric age group. So this is immature skeleton, right? This is young age group, while chondrosarcoma is elderly. Okay. So now look at the three tumors here. We have completed basically the tables from the first aid and tried to add on the important points. Now adding on some more images and extra points here. Image A, image B and image C. The three tumors which are commonly confused. So the first one is giant cell tumor, the second one is chondroblastoma, and the third one is ABC. Now we said that GCT and ABC, they look similar. Both of them are expansile eccentric lesions. But the difference is GCT, giant, is in a giant. That means in an adult patient after the fusion. That is mature skeleton. And it involves the epiphysis. Chondroblastoma, blastoma is before the fusion. Right? We generally use the term blastoma for pediatric. Right? So remember, this is before the fusion. And we know that this involves the epiphysis. It is ECG. So epiphysis is chondroblastoma GCT. ABC is exactly opposite of GCT. It is before the fusion and it involves the metaphysis, not the epiphysis. So look at the tumor here. This is a fused bone, right? You can see the expansile lesion going till the articular surface. So this is GCT. This is an unfused bone. You can see the growth plate there. It's an unfused bone involving the epiphysis. So this is chondroblastoma. This one is an expansile lesion. This is unfused bone involving the metaphysis. So this is ABC. Unfused metaphysis is ABC. Yes, absolutely right, Dr. Shubham. Another point to be remembered for chondroblastoma, remember histopath, pathologically, not radiologically. It has chicken wire calcification. Okay. So remember, it has chicken wire calcification that is present with chondroblastoma. Chicken wire calcification is seen with chondroblastoma. Okay. Now going to the next one, that is Aimingsarcoma. Now Aimingsarcoma, most important points to be remembered here. It has onion peel periosteal reaction. So like you see here in the image that I have added, look at the lamellated periosteal reaction, multiple layers like the onion there. So this is called as multi-lamellated periosteal reaction or onion peel periosteal reaction. What is the Ewing age group? Ewing is young. Ewing, young. Okay. So basically less than 15 years old boy, first decade. Very, very important. Remember, it involves the diaphysis. Femur is very common. So that means the shaft of the bone is involved. It can involve the flat bones like the ribs can be involved or the pelvic bone also can be involved. Okay. And remember that this tumor comes under the small round cell tumor. Okay. So the small blue cells are seen here which resemble the lymphocytes. It comes under your round cell tumor, the blue cell tumor that we have. Now, how do you differentiate it from conditions which can look similar? Because it resembles lymphocytes. So, it can look like lymphoma. It can resemble osteomyelitis also. Why? Because in Ewing's, also remember the important history in Ewing's, that the patient has history of fever also. Right? Fever is an important history there. Fever along with a lot of swelling is what the child presents with. Okay. And so how do you confirm that this is Ewing's? Is by testing for the translocation, that is 1122. So remember when I say Ewing's, so Ewing's is like 1122. EW, Ewing's has translocation involving 11 and 22. Remember all the double numbers for Ewing's. It is 1122 translocation. What is the CD marker for Ewing's? Remember the double number again, 99. So it is 112299. The CD marker is CD99 and CD99 basically is MIC2. Okay, that is MIC2. And the translocation is 1122. Okay. And this is an aggressive tumor. It's a malignant tumor. Early metastasis is there. But remember, it responds to chemotherapy. And this is highly radiosensitive also. Which is the most radiosensitive bone tumor? Aimingsarcoma is highly radiosensitive also. Okay, remember that. It is highly radiosensitive. Histopathologically, yes, this can give the pseudo-rosette appearance is what it can give. Very, very important. It can give the pseudo-rosette appearance. Okay, so that is for Aimingsarcoma, remember the diaphysis with the periosteal reaction, the onion peel, inner child, and translocation 1122, CD marker is CD99. It is highly radiosensitive. Okay. Next one, now tell me what bone tumor is this one here? Thank you, Rakesh, for those kind words. What bone tumor is this? So basically in a young patient, how do I know it's a young patient? Because this is unfused bone. This is a central lesion. This is not eccentric lesion. Plus there is this fallen fragment or the fallen leaf sign. So very, very important. What are we seeing here is the fallen leaf sign, or it is also called as the trapdoor sign. The fallen leaf sign or the trapdoor sign is what we are seeing here. Okay. So these are the findings of simple bone cyst. Okay. These are the findings of simple bone cyst, which is also called as unicameral bone cyst. Okay, which is also called as unicameral bone cyst because it's uniloculated. So what happens if there's a fracture in the cyst? The bone fragment will fall down because it is unilocular. Why the fallen leaf sign is not seen in ABC? Because it is multiloculated, so the trabeculations will block the falling of the bone, right? It will not go to the dependent part. So remember that it is fallen leaf sign, trapdoor sign, very, very important. What is the most common site here? For SBC, it is the proximal humerus, which is the most common site, like you can see here. That's the shoulder, the proximal one is the most common. Tell me what bone tumor is this? We have seen the images already. The sunburst pattern. Remember S for S, it is sarcoma with sarcoma, osteosarcoma. What bone tumor is this? This is the onion peel appearance. This is Aimingsarcoma, diaphysis. Okay, diaphysis. Quick revision here. What bone tumor is this? This is osteochondroma. Right, this is the osteochondroma. That is the cartilage cap will be present here. Okay, cartilage cap will be present here. When you have bilateral multiple osteochondromas, it is hereditary multiple exostosis. Generally, in that case, you have bilateral symmetrical osteochondromas, that is HME. This is a cortical based tumor with the nidus within OO, that is osteoid osteoma, which has the classical history of night pain, and the treatment for osteoid osteoma is RFA. That is what you are seeing here. Look at this electrode going into this area of the cortical thickening of the bone. So this image is basically showing the RFA which is being done for osteoid osteoma. The small bones of the hands, the 5 fingers. So remember the 5 fingers is the chondromas, which can show the stippled calcification. The small bones, olliers and Maffusis is what we have. And this one here involving the flat bone going beyond the bone margins. This is Chondrosarcoma. Popcorn calcification, rings and arcs pattern of calcification, endosteal scalloping is what we have. Okay? Right. So that was a quick review about the bone tumors. All the important points that you need to know for bone tumors. Like these are the must know. Very, very important. Right. So I hope this helps you in the quick revision of this topic. And from tomorrow, we are starting with the subject of physiology in the daily targets. So I'll share the targets for that, the schedule for that, like, what day you should be doing which system. And I hope along with orthopedics, you guys have also revised anatomy. Trust me, if you keep doing that, like along with the next subject, you revise the previous subject, at least the previous year questions, you'll be in a very good shape later on as well. Okay? No, Samriddhi, this was for today for orthopedics. And so no more session now. Today for orthopedics is what we'll be having. Okay? Thank you so much everyone, and goodbye, take care, and keep studying, keep revising, and keep winning. Thank you.